please give generously to the Neurological Foundation Annual Appeal so our researchers can focus on finding cures, not finding money. Check your mailbox for the appeal envelope.
Well, good morning, everyone. My name's Jane Sharman, and I'm from the Neurological Foundation, and I'm very pleased to be here today, and it's wonderful to see such a great turnout, so thank you all for coming along on Monday morning. I'm just going to run through a few housekeeping things. So this is a non-smoking venue, and outdoor ashtrays are provided beside both doors at the east foyer entrance downstairs. The toilets are just out to the left here, the ladies and gents. And in the unlikely event of an emergency, a siren will sound, a voice will tell you to evacuate the building. Please leave the venue immediately by the nearest exit, over here, and assemble on the grass area in front of the St John Church on Tay Street. A staff member or security officer will be available to guide you. And I'd just like to ask everyone to please turn their cell phones off or put them onto silent, just so that the lecture's not interrupted. I hope you enjoyed the lecture, and I'm now very pleased to welcome Councillor Darren Ludlow to introduce our guest speaker. Thank you.
Thanks and welcome along, everyone. It is absolutely splendid to see such a great turnout, and I'm thrilled to be able to welcome you to today's event, which is presented by the Neurological Foundation, an organisation that's had a much higher profile in the Otago Southern region over the last couple of years, which is very good. As Jane said, I'm Councillor Darren Ludlow and Deputy Mayor of Invercargill City, and I'm standing in for His Worship, Tim Shadbolt, who's been called away on business. Now, in case you weren't aware, the ad should have been a hint. This week is the Neurological Foundation's annual appeal week, and this event is actually part of a national lecture series that's aimed at raising awareness of the critical need for brain research funding. Might sound a strange thing to be coming from a politician, but thank you. The Neurological Foundation itself has actually raised over $40 million to fund brain research in the past 40 years, and they do need your help to continue with this work. On behalf of the Neurological Foundation, we'd like to make special mention of the 22-year anniversary that the Foundation is celebrating with Mitre 10. You might not have been aware of this, but Mitre 10 actually sponsor the Foundation's annual appeal. They pay for the production and print of the appeal envelopes, which help to spread out the Foundation's message right across the country. Quite simply, without Mitre 10 and their very passionate staff, the Foundation wouldn't be in a position to have an appeal week. So thank you to Mitre 10. The Neurological Foundation is the only non-government neurological research funding body in New Zealand, and over 98% of their funding comes from public donations. The other 2% or so comes from trusts or grant bodies. Funding for brain research is needed today more than ever to improve the outcomes for the growing number of New Zealanders who are being diagnosed with neurological disorders. As our population ages, so too does the number of these disorders. And the only way to end neurological disease is with the best research. Research is, however, making remarkable progress, as you will find out from today's speaker. Dr. Andrew Clarkson and his colleagues from the University of Otago have contributed hugely to the advancement of neurological research, and their passion and commitment to improving the odds for patients is significant. The Neurological Foundation has funded much of their outstanding work, and I'm very pleased to announce, ahead of the media release that will come out later on today, that in the July funding round, over half of the grant budget has been awarded to University of Otago scientists. So I encourage you to join and support the Neurological Foundation to help keep this incredible and important work going. A little about today's speaker. Dr. Andrew Clarkson is a Senior Research Fellow in the Department of Anatomy at the University of Otago. His current research focuses on the processes involved in post-stroke regeneration and repair, and recovery of function after a stroke. Dr. Clarkson and his research colleagues at the universities of Otago and California made worldwide news headlines 2 years ago with their discovery of the regenerative effect of a drug compound for stroke recovery. The results of the study, which Dr. Clarkson led, have been published online in the scientific journal Nature. The research is continuing, and human trials for the drug are being explored. In 2009, Dr. Clarkson was awarded a Neurological Foundation Repatriation Fellowship, which enabled him to return from the UCLA to the University of Otago. Would you please join me in welcoming Dr. Andrew Clarkson.
Well, thank you for those very warm welcome and wishes. So today's lecture, I was going to sort of discuss some of our recent findings and continuation of where we're going with our research, trying to understand how the brain can actually repair itself following stroke. I mean, my interest sort of stems further than that. During my PhD and early careers, we were actually looking at compounds to try and minimise the extent of cell death. But the way we're heading now is to actually look at and try and understand how we can actually give back function, sort of more at the delayed period, because this is an untapped field. It's an area of research which is in high demand, and currently in New Zealand there's about 55,000 people who have had a stroke, have some impairment, but we can't actually give them any hope apart from remedial therapy. To be honest, I feel a little bit intimidated standing up here, especially after the recent campaigns which have been going on over the last 2 years. I mean, this year's sort of appeal for money from the Neurological Foundation. But as we all know, a couple of years ago, Dunedin sort of threatened to can the neurosurgery unit, and it was all going to go to Christchurch. So there was a huge campaign to get funding for a neurosurgeon. And we're very fortunate to have this guy here, Dirk de Ruyter, from the Netherlands, and so hopefully at some point Dirk will come down and actually give a lecture to you guys, talk about his research. Dirk does a lot of work looking at deep brain stimulation, different electrical patterns of stimulation to actually try and aid in functional recovery, sort of primarily in the field of tinnitus research, but he's also done other pathologies as well. So he's a great asset at the moment in the hospital up in Dunedin, and he's starting to build a team around him. So the brain itself is a very fascinating organ. It's probably the most complex system in the universe. It only weighs about 1.3 kilograms, so it's about 1 to 2% of our body weight. But there's about 100 billion neurons. So these are the primary nerve cells in the brain. So that's a huge number of cells. Each of these cells has probably 1,000 to 10,000 different connections. So they could constantly communicating to each other. These communications can be from one hemisphere of the brain to the other hemisphere. And they can also be right down into the spinal cord as well. If we look at just the blood vessels, and if we were to take them all out, lay them, in lengthwise, there's about 100,000 miles of, networks there. So it's a very fascinating thing. So if some little incident was to happen on one of those roadworks, for instance, then you can see, something very bad is going to happen. So this network is fundamental in terms of keeping the brain going. The blood vessels themselves supply all of the oxygen, nutrients, everything to the brain. So if you were to disrupt one of those connections, then you're starving potentially a few thousand of these nerve cells in the brain. Once you've starved them of any sort of oxygen and nutrients, then they will die off, and then you can actually see a cascade of events following that. So their neighbouring cells will be at risk, compromised, and then once they're compromised, then the next cell next to them will become compromised. In addition to this, the brain receives at least 20% of all oxygen and nutrients that we consume. And so because of that, this little organ in the brain is probably the most interesting organ to me because it is so complex in its fundamental operation. This is just a CT scan here. This patient's had a stroke to the middle cerebral artery territory. This is a region of the brain which controls movement, so limb movement, upper limb, lower limb movement. And we're very interested in this region because it's a region in the brain which is affected in about 60% of all stroke patients. And it's the main area, the main branch of the artery comes up and sort of bifurcates in this area here, and so we see this anterior portion of the brain, so that's the front part of the brain, which controls primarily upper limb. That's the main area which is affected. So worldwide, stroke is actually the third, and in some countries the second leading cause of death. And unfortunately that's not getting better. If anything, it's going to get worse with the ageing population. But what most people forget about is that at least 75% of all people who have had a stroke will actually survive. And most likely they'll have some form of disability. So this could be speech impairment, visual impairment. We talked about lower limb sort of motor impairments, upper limb, extremity and motor limb impairments. Cognitive impairments, I mean that's a big thing at the moment. People come to me and talk about the impairment and the ability to remember. Can we actually do anything about that? And so that's an area of research which we're just getting into now. So potentially some of the compounds that we're testing for look at motor recovery may be also beneficial for cognitive impairment. And so we're trying to tease out that whether it's true or not. It's estimated that it's costing the government about $1 billion annually just to treat these patients. This is sort of remedial therapies, the initial care in the hospitals, which can vary from at least 1 week to 2 weeks. And so this is probably the most out of any sort of pathology that the government's spending. Alzheimer's, Parkinson's are getting a lot less than this. And so it's a huge burden, cost burden to the government, taxpayers. And so if we could potentially have a therapy which we can actually give back some motor recovery, then these patients can actually get back out, enjoy their life again. Because most often a stroke patient will have a stroke, they become very depressed, they become reclusive and stay in their own home. And so what we want to do is actually give them just a little bit of hope, give them some motor recovery, they can lose that depressive state, and then they're back out in the open and enjoying their jobs and carrying on. So the biggest reason for this loss of impairment or motor recovery, so to speak, is it's largely due to disruption of connections throughout the brain. And these connections can be sort of distant or long distance. So this is just a couple of schematics. For instance, we've got a stroke here. Connections can actually start in the top of the brain. They can then cross over at the cerebellum, so the back of the brain here, and then carry on right down into the spinal cord, and that's where they terminate to actually initiate the end-point motor output. Connections can also go from one hemisphere to the other hemisphere. These connections are often disrupted after a stroke. But what we're more interested in is actually looking at these local connections. So if you had a stroke here, this is in the brain about the motor cortex. Then we've got the somatosensory, so this is around the cheeks, the eyes, sort of touch area, the mouth. And then you have the retrosplenial cortex and other premotor areas. So there's several areas in the brain which can actually sort of control and initiate movement. And what we're trying to do is understand how all of these regions in the brain may take on board some of that lost function. The biggest thing is if you lose, for instance, this is a stroke, this is a schematic of it's a mouse brain. This is a region which is just crossing over from motor cortex to the sensory motor, so that's the whiskers in the mouse. High order function. These stimulations come into the motor cortex to understand where the mouse is going to walk to and understand their pattern of movement. These other regions next to that region, that stroke, need to take on board those lost functions. If they don't do that, then that animal, or us as humans, will never recover. And so what we're trying to do is actually understand how that occurs. And there's many sort of theories about this. You can actually sprout new connections. So this is regions of the brain. Those nerve cells can actually sprout a new connection to terminate where the stroke was going to happen. And so with that, then they can actually take on some function. We have processes in the brain where you can actually stimulate new blood vessel growth. So you can actually reintroduce nutrient and oxygen supply. Different parts of the brain can also sprout new neurons themselves, new brain cells. Whether those brain cells can actually migrate to the site of injury and actually survive is still under debate, but that's also another mechanism. And more recently, we've looked at sort of another mechanism that we found where the brain is actually just put to sleep. So not all of these connections are lost, which we first thought. They're just being silenced, and so it's almost like putting up a stop sign, and the traffic's not going to go past that point because it's illegal. But if you take that stop sign down, then the traffic can actually flow again. And so that's what we're exploring in terms of looking at enhancing recovery. So there's multiple forms of stroke. I've listed 3 here. Most people are quite familiar with probably 2. The first and the most prominent is the ischemic stroke. This is a diagram up here of what actually happens. You get the build-up of plaque. This is the blood trying to come through. The passages just become too narrow, and so what happens is the blood clots, stops there, and then beyond this point it's now starved of oxygen. This is at the bifurcation of the middle cerebral artery, as I was talking about earlier, and it's hard to see, but this area here is in grey, and that grey area is the tissue which has been starved of oxygen and nutrients. And so that region will then die off, similar to that CT scan that I showed on the first slide. Another form of stroke is the hemorrhagic stroke, which accounts for about 15% of all strokes. This occurs due to a weakening in the vessel. Usually the blood flows up here, and because it's got a bifurcation, traverse all the way up, it puts a lot of pressure on these joints, and so at some point it can actually just rupture and just spontaneous rupture, and then you just get a bleed out. All of these forms of stroke cause tissue damage, cell death. In the most severe cases, with the hemorrhagic stroke, neurosurgeons go in and they try and clamp off the bleed and actually suck out the blood. The other form of stroke is what we call a TIA. So it's very similar to an ischemic stroke, so it's a transient ischemic attack. And with this, what happens is usually it's more of a warning sign. It's a very small stroke which happens in the brain, and usually the signs will recover. So if you have a little bit of motor impairment, similar to what you would have with an ischemic stroke, you usually regain that function within 24 hours. So the only difference between an ischemic event and a TIA is that you recover all function within 24 hours. It's possible to have hundreds of these TIAs, and we're quite concerned about these TIAs because multiple TIAs can actually cause dementia. And it's a very specific form of Alzheimer's or dementia. It's called stroke-induced dementia, and it's well documented now. And it often happens in regions where you have very distinct regions of the brain, of course, which control learning and memory. And so it often happens in those regions, and that's why you end up with this dementia, rather than in classic motor regions. And so I notice at the back of the room, the Stroke Foundation has some of these pamphlets as well, and so we often try and promote this. There's 4 distinct sort of warning signs, so we call it the FAST. And so if someone is actually having an ischemic event, you can actually look at them and sort of quickly scan through the list and say, okay, do they have sort of facial impairments? Do they have a sagging of one side of the face, a droopiness? Can they actually put their arms up and actually hold them up? So if they put them up straight, does one just drop down? And so they have impairment there. Are they having difficulty speeching? So almost like that they've been on the booze and they're drunk, the slurring their speech. It's literally that common, that distinct. And also, we say time. So if you see anyone with these sort of impairments, and I've actually diagnosed a few people over the phone, especially around the speech component, saying, okay, it's possible you're actually having a stroke with the partner's rung up, you should actually get into the hospital ASAP. And the reason we say time is critical is because, and I'll get onto it in a couple of slides, is every minute that you wait, you're probably losing 1,000 to 10,000 nerve cells in the brain, which is quite phenomenal when you think about it. But this is just a statistic we chuck up. This was from a paper of a colleague of mine in the US, and he was extrapolating back in 2002 in the US. There's about 700,000 people having strokes, and he mapped this out. And by about 2025, he's estimating close to 1.2 million people in the US alone having a stroke. Most of these are due to sort of comorbidities. People have hypertension, hyperlipidemia, so high lipids in the blood because of poor diet, diabetes, smoking, high alcohol intake. All of these factors can contribute to a stroke. So if you were to minimise these factors, then potentially you could actually decrease your risk factor. But if you actually look at this red line up here, this red line is also increasing, and that's solely due to the fact that we are ageing as people. We can't prevent ageing, but with age, every pathology that you can think of is actually, you increase the likelihood of actually having a stroke, you increase the likelihood of developing Alzheimer's, you increase the likelihood of having Parkinson's or Huntington's disease, which affects a deep brain structure called the striatum. We can't prevent that. And so us as neuroscientists are trying to find ways to actually try and treat, new therapies to treat. And I think that's the only way forward. And so I'm going to touch on a few of these different treatments, one that I'm working on, specifically one that I was also working on in the US, looking at stem cell therapies, which is a very hot topic at the moment as well. And try and give some people some hope that in the future, I know of several clinical trials starting around the stem cell therapies, so potentially there is some hope there at the moment. So as I was saying, time is brain cells, and so this is another schematic that we like to show. So very early on, this dark spot here is where the stroke happens. So this is the epicenter. Then we have this sort of shaded area surrounding that sort of epicenter. That region is a region which is at risk. And so if we were to wait sort of minutes to hours, you can actually see that the core or the epicenter is expanding, getting larger, and taking over a lot of that shaded area. So that initial stroke is actually just getting bigger and bigger and bigger. And then usually about 2 to 3 days later, you have a fully formed stroke, and then you don't have so much of tissue which is at risk. We should be circling another region around here, which is sort of compromised tissue. That region surrounding this fully formed stroke is the region that we're interested in, because that's the tissue which is most plastic. And so when I talk about brain being plastic, it means we can actually sort of stimulate it or alter its sort of chemistry. And that, if we do that within a couple of weeks, then we can actually maximise the recovery. It's also this region that we found is put to sleep. So that's where most of the sprouting of new blood vessels happens. That's where we can actually sort of reawaken those connections. This is what we neurologists see when they actually put patients into a CT scanner or MRI scanner. You can actually do two different stimulus paradigms. The first tells us, the diffusion-weighted imaging tells us where the initial stroke happens. So that's tissue which is dead. That's the initial core. That's dead tissue here. And then we have a perfusion-weighted imaging. So this tells us here, you can actually see the blue is nice, healthy tissue which has blood flow going through it. It's fully oxygenated. Whereas the red tissue here and also this yellowy tissue, greeny tissue, is compromised tissue. So you have very poor perfusion in that area. And so if you actually overlay these, then you can actually see here, this is the core, this is where the stroke happened, and this is the region that's at risk. And that's the region that we're trying to prevent initially for cell death. So we can actually try and minimise the expansion of the stroke into this area. And if we don't do that, then we sort of target the surrounding tissue to try and give back function. One way of thinking about this is not too dissimilar to what happens after an earthquake. So people will be very aware, this is the Christchurch earthquake. You actually have the epicenter, so the destruction happens at the epicenter, and you have these concentric circles, and the further you go away, the less damage there is, the less impairment. This impairment at the epicenter is very catastrophic. Damage takes weeks to months to sort of remove that debris. Similar processes happen in the brain. So there's very specialised cells in the brain which can come in, like we have workers that come in, take away this debris, and the brain actually does that itself. But it does take months. We also have disruption to the roading system. The roading system in the brain is our blood vessels. So if you were to disrupt the roading system, then you're not going to have transport in. The cells which want to get there to help recover can't get in. We can't get the oxygen there. We can't get the nutrients there. Likewise, we have disruption to telecommunications. And so the same thing happens in the brain. So our nerve cells, the primary cells in the brain, they're surrounded by different cells called oligodendrocytes, very specialised cells, and they actually help the conductance of electrical or chemical signals through the brain, very similar to what we have here for telecommunications. Without that, then the cells can't communicate to each other. And so what we're trying to understand is how all of these mechanisms happen in the brain. Okay, we know that we can actually modulate, for instance, the Rodian systems to actually give back some sprouting of new blood vessels. We're looking at processes now for looking at nerve cell conductance, so how they actually communicate in the brain. Can we actually give back more function? And so I think unlocking the silentness, for instance, is one mechanism. And then we're also trying to understand which chemicals in the brain are actually given all the signals. So there's some very bad chemicals or cells in the brain called astrocytes. They're actually good cells as well. So at the initial part after a stroke, the astrocytes become reactive, and they actually form this nice glial scar. But the glial scar is also a hindrance. And so early on, you want a really nice glial scar to minimise the extent of cell death, but at a delay, you want to take that glial scar away because it's releasing a lot of factors to say, hey, don't come here. This is bad territory to come. And it's because of that, it's because the cell and the brains in that region have become silenced. And so we're actually looking at different ways to actually dampen or alter that glial scar as well. So stroke research has actually had a lot of bad press, and so solely because us as researchers, we've trialled well over 1,000 compounds, and actually none of these actually translated into the clinic. And I think there's a number of reasons for this, but mostly it's because we can't get in there early enough. And so because time is brain cells, we need to get in there really early, within hours. And often, stroke happens during the night. The patient doesn't know about it until, the morning. They don't want to, be a hindrance, tell their partner about it. So maybe mid-afternoon, they may go in and say, okay, actually something is wrong. And so it's about 12 to 24 hours usually that they get seen, which is probably a period where we can't do anything in terms of minimising the extent of cell death. And for that reason, all of these stroke therapies actually probably failed. Of all of those therapies which we had trialled, 50 to 60 have gone to clinical trials. None of them passed clinical trials. All of these clinical trials cost up to $1 to $3 billion. So this has put a lot of press onto drug farm, big pharma, so Roche, AstraZeneca, Lundbeck. These are some of the big pharmaceutical companies who are very active in the stroke field. All of them have pulled out of research into the stroke area, solely because they can't keep footing the bill for clinical trials of this magnitude. And so we're trying to change the way we actually test our compounds preclinically now to actually make them more efficacious. And so we've changed the way we look at our animal models, some of our testing and screening of the compounds. And I know of 2 or 3 different compounds which are in clinical trial now which are showing great promise. The only thing that we do have is a compound called tissue plasminogen activator. So this is a clot buster. This actually comes from the cardiovascular research rather than neuroscience research itself. And actually the new generation clot busters have a therapeutic window of 6 hours, which sort of means at least 10%, if not 15% of all people who have a stroke, at least an ischemic stroke, can actually get this compound. And what it does, it just breaks down that clot so you can actually get blood supply back into the region which is damaged. And so that's a good thing because then that aids in recovery of functions. But do we actually have anything better on the horizon? And so one way of actually looking at sort of the brain itself is it's almost like a scale. And so in its very crude sense, you have part of the brain which is controlling inhibition, which sort of silences everything in the brain. And the other part, you actually have cells which control excitation. So this is really making everything alive. And after, say, stroke or epilepsy, you often see this imbalance. So if we have, for instance, epilepsy, you have overexcitation. And so that's when you cause seizures. Seizures also occur after stroke as well. And so we know that what happens is you get this decrease in inhibition and increase in excitation after stroke. So this is a very simple way of actually viewing what's actually happening in terms of looking at the chemistry in the brain. What we've found is actually probably the opposite also happens. And so very distinct cells or very specific cells in the brain which usually control inhibition are also controlling excitation. And so us as neuroscientists, it's quite confusing in terms of trying to find a therapy, because if we're actually trying to dampen excitation but we're actually looking at boost inhibition, we're also altering the excitation. So it's a little bit confusing for us, and so we're very slow in moving forward on our research, because we need to work out exactly which brain cells are doing which, and so we don't want to give a therapy which could actually cause a stroke patient to actually have a seizure increased seizure activity. One chemical or drug which is actually in clinical trial now, which is actually showing good promise, is a compound called PSD95, and it's solely what this compound is doing is disrupting the level of excitability in the brain. And its therapeutic window is out beyond 6 hours, so they reckon at least 8 hours. So it's better than the clotbusters, and what they're trying to do is actually combine it with the clotbusters, and that's when we're going to see the maximum therapy. This is in clinical trial at the moment in the US and Canada. Whether it goes through to full clinical trial worldwide, it's under debate, but it's the data which was presented a few months ago is looking very promising. So this is something which can actually minimise cell death in the brain. We're also trying to do the same here, and so I've partnered up with a couple of pharmaceutical companies as well as some chemists in Sydney and also in Copenhagen. And instead of looking at the excitatory pathway, we're looking at the inhibitory pathway, because that's my area of research. And so we're in the process of screening compounds at the moment, and so this is what we actually look at when we sort of screen a compound. We can see two images here. This is from a mouse brain. This is what we see when we look at a stroke in the mouse brain, and the stroke is actually happening in the motor cortex. So this is where we control sort of lower limb function and also upper limb function. This compound that we were looking at, if we were to give it after the stroke, that's when we want to give it, of course, we can actually see quite a significant decrease in the area of damage as compared to this control here. So this is what we want to see when we're looking at screening compounds. If we were to quantify this, we've looked at several compounds. This is one compound, Zolpidem, which is FDA approved. It's out in the market. It has a lot of side effects, but it's been also used to treat patients with sleeping disorders. It's very difficult to get in New Zealand, so a lot of people in the States have these new generation compounds. But what we see here is this is the stroke. If we were to give the compound, you can actually see a small decrease in the level of damage. So this is total sort of stroke volume. The new compounds that we've been looking at, this is a couple of them. The first is called THIP, or Gaboxidol. This compound has been trialled for alcohol withdrawal. So these aren't classic drugs that you would think, okay, this might be good for treating stroke. We're actually going sort of off-market and looking at very specific compounds because we're trying to target a very specific part on the GABA receptors. So these are receptors in the brain which control inhibition. And it's once we target very specific components, that's when we can actually enhance and maximize the recovery. This compound here is a new compound that was given to me from a group in Sydney, and we're looking at this a lot more now because it's very, very low dosing. We can actually see quite a significant decrease in that stroke volume. A lot better than what we can see with this compound here, which is used for alcohol withdrawal, and a lot better than the compound that we showed previously, which is being used for sleep disorders. And it's this targeting that we're sort of trying to get. This level of recovery is ideal, especially for delivery of these compounds very early on after the stroke. Whether it can go through to clinical trial, we're not too sure, but that's much further down the line. But most of my research over the recent years has actually been looking at recovery profiles. As I was saying, 75% of all stroke patients will survive. They have some form of disability. Can we actually give them some hope. At the moment, there's, all stroke patients have is remedial therapy. That's very limited as well. And so if we can actually have a drug therapy which they can take in conjunction, say, with remedial therapy, then the likelihood of them actually recovering and getting back in, normal daily living is going to be much better. So we know the brain can sort of recover and regain functions. And so this is just two images. I'll step you through this. The bottom one here is some imaging from a cohort of stroke patients. This is using PET imaging. And what the patients have done here is they've actually tried to look at remapping of the fingers. And so if you would take your thumb and just tap it to your forefingers, etc., and just rotate it through, then you can actually see the brain will light up to that. And people can actually image that using different forms of imaging, MRI, PET imaging, to a certain degree CT imaging as well. In patients that regain function, and so what they had done here is they had a coil just placed over the motor cortex, and using electrical stimulation you can actually stimulate the brain to try and reprogram or stimulate the recovery. In those patients that showed good recovery, you can actually see quite a large area of activation. And it's that enlargement of area of activation compared to the stroke patients that showed no recovery, which tells us that that brain area, which is down here, so this is part of the motor cortex, and also sensory areas, so that's the touch areas, which are actually compensating and actually taking on board those lost functions. We've also seen more recently in animal studies that if you create very small lesions to part of the forelimb area, and for instance this is the hind limb area, you can actually see, this is the lesion, you can see quite an enlargement of this rostral forelimb area. So this is what we call the premotor. So it's almost, you could think of this as a truck and trailer system. So the premotor feeds into your primary motor, which then feeds into hind limb. And so expansion here tells us that the premotor area is actually kicking in, taking on board those lost functions and actually stimulating some recovery processes. But we can also see this remapping of the red, which is also the touch and the sensation parts of the brain. So we do know that recovery does occur, but what we don't know is actually how this is really occurring. And so there's a lot of intense research going on. Is this truly a sprouting response? So this is new neurons reaching out, sprouting new connections, which has taken on the lost function? Or were these regions sort of, to some degree, already doing the function, but when they're silenced, or it's more, probably maybe a secondary function that they need to come on board? And so usually if it's a secondary function, that it's not going to be active on its primary task. But after a stroke, for instance, then maybe we can reawaken the secondary functions, and that's where we're seeing the recovery. So I can just highlight just a couple of ways that we can actually look at this. So sprouting of new nerve cell connections, or if you don't see the sprouting, then that can actually impair the recovery. We also know that there's several, if not several hundred molecules which are released in the brain which can actually impair recovery. So we're sort of systematically going through and targeting these different compounds. Is it compound A, which is causing the impedance or inhibitory component? Is it compound X, which is doing that? And so we need to systematically go through that to understand which compounds are doing which function. We know that rehabilitation does work, and the most sort of active and pursued at the moment is rehabilitation, so forced overuse of the sort of impaired limb. We know that that does work, and actually that forced overuse gives back the most function, at least clinically. And so what we're trying to do is understand also forced overuse. How does that reactivate the brain? So this is some data that we collected just recently using a model system which is in dish. And so we can actually take different brain cells out and culture them up in a dish. So this is just in a petri dish. What we can actually see, that the blue here is just all the cells. This green cell here is a primary nerve cell. So this is one of our main cells in the brain which we want to sort of activate and stimulate its recovery. And then we can actually see these red cells here. So these are the cells, we call them support cells. These are the astrocytes. And so after an injury, they become reactive. And actually, after injury, you can actually see quite a significant increase in red here. Those cells have become reactive, and actually they're releasing a lot of factors which are inhibiting the outgrowth of cells. And actually you can see this quite nicely here. This is one of the nerve cells which was cultured on top of these. And if you look at its process, it's quite sort of short and truncated. It's having a lot of difficulty actually growing in this condition. Compared to a control system here, a nice healthy area, you can see really nice elongation of those processes. This happens in the brain as well, and so we can actually give back different factors to this system here to actually see, can we actually stimulate the outgrowth? Can we actually promote this cell here to actually grow like this guy? And if we could do that, then we can actually say, okay, can we then take this back to the brain, give back a system or a chemical to actually promote recovery? And there's a lot of research in our lab going on looking at this. There's a lot of research, especially where I came from in the US at UCLA, understanding what systems are being released by these guys, the reactive sites, which are actually inhibiting the outgrowth here. So the biggest part of my research is actually trying, not so much understanding the axonal outgrowth, but understanding the learning and memory component of this. So it's one thing to say, okay, we can actually stimulate the outgrowth of new connections, but in order for that new nerve cell to take on board the lost function, it needs to learn or relearn what was lost. And so this follows sort of very classic paradigms in the brain which we know occur, looking at learning and memory. One of the most sort of studied chemical or compound is amphetamines. Amphetamines are known to enhance learning and memory. They can, after stroke, people have trialled them to look at motor recovery. This also happens. But amphetamines are very dirty drugs. And so we're looking at, this is sort of why we got into this area, because if you start to look at very specific pathways, as I was saying, that's when you can actually decrease all the side effects and actually enhance the recovery. So over recent years, there's a class of compounds called cognitive enhancers, solely developed by pharmaceutical companies to treat Alzheimer's patients or patients who have impairment in learning and memory. And so we've been looking at these compounds also because, all right, so I mean, as I was saying, my interest is looking at these new compounds called cognitive enhancers. I'll skip through a couple of these slides for interest time. And so what we're doing is we're looking at different regions of the brain. And so over recent years, we've established several models of stroke to actually target very distinct regions in the brain. So most people up until now haven't been doing this. And so when you actually give a compound, it may not work in a very specific region of the brain. And so what we're doing is actually screening these compounds in very discrete regions. For instance, the motor cortex, which controls primarily movement. This is the region of the brain which is people are thought to be primarily involved in Parkinson's and Huntington's. So this is a deep brain structure called the striatum. Stroke also happens here. It's also involved in movement as well. And then we have these very, very small strokes here, which we, if we were to look at a CT or MRI, it's called a lacuna stroke. So it happens to be in the white matter tracts. And disruption to these white matter tracts can also disrupt movement. And so if you were to actually look at this on a task, at least in rodents, to look at fall and function, and you can put these mice on elevated grids to walk around naturally, similar to what we would do naturally just to walk around on the street or on a treadmill, you can actually look at impairment in how they walk. And so naturally, this is how they behave. So nice, even baseline measurements, normal, healthy animal. However, after a stroke, you can see quite a significant impairment, for instance. So if you had a stroke on the right side, it'll be impairment on the left side of the limb. And so you can see this impairment, and with the motor cortex, the cortex here, you can see a nice gain of function over time. However, if this stroke was to happen in this deep brain structure, in the striatum, we don't see recovery over time at all. And so without these sort of different models, we wouldn't have been able to pick this up. So whether our compounds are actually working, but we know they work quite nicely in this model, whether they work in this model is a different story. Likewise, do they actually work in these small lacuna strokes? So the recovery, or even the profile, is very different to this model. It takes about 2 weeks to see full impairment in motor function. and then they start to recover. That's very similar to what we see in humans. So with these models, we can actually dissect out regionality and whether various compounds will work in each region, or whether one therapy maybe actually will cover everything. So this is one way of actually viewing what we see in the brain. So this is what we see as a nerve cell. It's nucleus, so this is where all the and the genetic makeup is held in the cell. And then they have these really elaborate processes. And actually this flash of light here and here is actually the electrical conductance, which passes from one nerve cell to another. And we're interested in looking at this sort of electrical conductance to actually understand, is this impaired? How is it, these cells communicating, and actually can we give back or enhance this electrical conductance? And this is sort of a trace of what we actually see. So every chemical in the brain has a very distinct sort of signature. And so if you were to take a very, very small electrode and just lightly touch this to a nerve cell in the brain, then you can actually pick up various electrical signals. And so that's what we're doing here. And this electrical pattern here, or signature, is what we see in a very healthy cell, whereas what you can see here is a slight deviation in this baseline. And it's this slight upward deviation which tells us that there's a little bit more inhibition in the brain. This inhibition is actually there for weeks to months after the stroke. So we know that this change is actually causing a lot of sort of impairment and sort of recovery. And so what we can actually do, we can actually map this out. This is what we see after stroke, quite a significant increase in that electrical activity. But if we were to dampen that, and so this is where we sort of got quite excited about this study, is that this is the normal profile of recovery over time. If we were to give this drug, this is just this is the drug here that we were looking at initially. What we could see is we could see quite a significant gain of function. So the animals pretty much got better more or less straight away. So we know that this drug has to be on board for the full duration of the study. We don't know how long we actually have to give the compound at this stage. We're still working that out. But we do know if we actually wait, this is 3 days in animal studies, we can wait even 14 days and still see similar recovery. So that's probably weeks to months in humans after a stroke, which is quite an ideal time to be starting our sort of therapy. I'll skip over that one. We also know that it works for all ages. Stroke is thought to be a pathology which happens only in age, but it can actually happen to anyone at any time, any age. I've got neurologists in Auckland who see probably one patient a week in their 20s. And then as you age, the incidence actually increases. So it does affect everyone, and the males, females, no discrimination at any time. And so what we can see here, the red lines are what we see as aged animals. So these animals are equivalent to about 75, 80 years of age in human terms. But what we want to point out is, compared to the black, which is probably a young adult, what we can see is this deviation with the drug treatment on both the young and the aged is quite similar, which is ideal. That's what we want to see. So this drug therapy that we're looking at is beneficial for all ages, and we're working out whether it's the same for both males and females. Probably have to switch to a different drug for females, but we're working through that at the moment. We can also look at this using different imaging techniques as well. This is just one technique. It's almost like an MRI in a mouse. And what we can actually do is we can actually look at changes in oxygenation in the brain. So if you put a little bit of a stimulation to, say, your finger or your palm of your hand, then you can actually see deoxygenation in the corresponding brain region. So that's effectively all we're doing here. And so if we wish to stimulate the forelimb here, you can see this dark spot here, that's the forelimb region in the mouse brain. So we can actually see deoxygenation, so it's been activated, so to speak. And you can actually map this out on different sort of colour scales. If we were to look at this in two different populations, one, this animal here hasn't had any treatment, 7 days after stroke, you can see pretty much no activation of the forelimb area, so no stimulation pattern on this forelimb area. However, with our drug treatment, you can actually see quite a significant activation pattern. It's quite scattered, If we wait several weeks, then the scattering comes together and you can see nice focal area of activation. So more or less see nice recovery profiles. This is what we want to see, nice activation patterns. That tells us that different regions in the brain become unlocked, and it's in that unlocking or desilencing that we see functional recovery. So these were the very first studies which sort of told us about, that we can actually reawaken the brain, so to speak. And we've followed on for a number of different studies to actually try and classify how long after a stroke, which drug therapies are the best, and we've also targeting different sites on our nerve cells as well to actually see if we can actually enhance recovery. We know that there's different windows after a stroke. For instance, you have that very acute period when you want to minimise cell death. Then we see now that the subacute period, which is probably 3 to 14 days, which is probably 2 to 3 months in humans. And then we have a window which is looking at delayed, prolonged therapy. So that's months to years after a stroke. And each period will need a different compound or different drug. And we're sort of working out which drug is best for which window. This is a drug, the zolpidem, which we were trialling initially for protection. We also know that it actually works at that delayed, very far window. So this was an N of 1, anecdotal evidence that it does actually work. This 52-year-old woman had a stroke to the left motor cortex, but she was still having quite significant impairments and sort of sleeping. And so the neurologist prescribed her this zolpidem to help for her sleep and her insomnia. But what they actually noticed was that provided the zolpidem was on board, she could actually regain speech. So we do know that these drug therapies do work, even at the far, far delay. So this was actually 2.5 years after a stroke, or 3 years later actually. And so we're actually now also looking at this compound, but some very similar. Zolpidem has a lot of side effects, and so we don't want to go to clinical trial with this, but we're looking at a couple of therapies which we hopefully will be able to go to clinical trial with. I'll skip over these. So the last couple of slides, I just want to touch on stem cells. A lot of people actually ask me about stem cell therapy. And so there's two different populations of stem cells, those which are born naturally in the brain themselves and actually can regenerate, whereas those that we can actually grow up in a dish and then put back. And so a few years ago, a group in Auckland, led by Maurice Curtis, Richard Fall, they actually discovered and actually have shown for the first time that actually stem cells do grow in humans. And so this is an image of the human brain. These dark red cells here with these long processes, those are actually new cells in the brain. This is just confirming it here with another stain, so you can actually see this is a nice neuron. This is actually what it looks like. So we do know that the human brain, like our animal brains, can actually grow and stimulate the growth of new cells. We know that they play a very important role, this regeneration, in terms of learning and memory. So this is a region in the brain. You can actually see really nice cells, these green cells here with these long processes. These are new cells which have been born within, say, a week of actually staining and looking at these. If we were to knock them down, then you can see impairment. But if we were to give a drug then to stimulate the growth again, you can actually see nice learning or relearning. So we do know in very discrete regions of the brain that these new cells in the brain are important for learning and memory. A lot of work has also been now looking to see if they can actually migrate to the site of stroke. This is a mouse brain here, this is the stroke here. The birth of these cells happen at the lining here of the ventricle. So the ventricle is which allows sort of brain juice to flow through the brain to actually supply some of the oxygen, nutrients and chemicals. The dark spots here which can migrate out, those are the birth of the new cells from that region. We do know that they do migrate there. This is a high power image here using colour. All of these dots are new cells which actually migrate to the site of injury. We also can show even high power here. This is a nice cell with beautiful long processes. These cells here are normal cells which are already there in the brain, but it takes several days for the birth and migration of these cells to occur. So that's quite a significant delay which we don't want. And so we're at the moment we're trying to understand, can we actually stimulate the birth earlier so we can actually get migration, say, around 3 days rather than the 7-day period, which is when we want to see maximum recovery. the interesting thing is when the group that I was in the States, when we were doing these studies, we noted that they actually migrate along blood vessels. And so without the sort of stimulation of new blood vessel growth, these cells don't actually migrate. So this is a nice high power image here. The green here is actually the blood vessels. So this is just like the highways, so to speak. And so without the highways, the traffic won't flow along here. The cells actually line the highways, and actually travel. So if you were to have a disruption in that connection, then there's no way that they'll get there. So we do know now that we have to stimulate both the blood vessel growth to the region of injury as well as actually stimulating new cell growth. And so there's a lot of emphasis on stimulating blood vessels compared to stem cells or the birth of new stem cells. And I think that's the way forward in terms of this research. Once we can actually stimulate the blood vessels to grow better, then I think that the stem cells, the natural stem cells, will just proliferate, start to grow, and then migrate on their own. The other big area of research is actually growing up stem cells in dish and then giving back and transplanting them in. And there's a clinical trial on at the moment in the UK, and I know there's going to be a clinical trial starting next year in the US as well, based around some of these results here. And so what we've done here is we've taken these cells which are grown in dish, put them into a matrix to actually support them, and then actually put the matrix with the stem cells into the stroke itself. And so what we can actually see is this matrix enhances the survival, so we get better survival of the stem cells compared to just stem cells alone. And it's this matrix that they're in could actually then further enhance the recovery. So again, this is just the behaviour of the animals. This is how they behave normally. If you put those stem cells in that matrix into the stroke, they integrate and you can see really nice behavioural recovery. This is full limb function. And so huge research is going on at the moment. There's a $20 million grant between Stanford and UCLA to develop this, and I know they're actually planning on clinical trials next year. That's led out of Stanford based on this work. And certainly this work wouldn't have been possible without the funding, of course. I've had quite a significant amount of funding from the Neurological Foundation over the years. I had a Philip Wrightson Fellowship, followed by the Repatriation Fellowship, and more recently picked up another project grant. But I'm also in quite close collaborations now with Roche Pharmaceuticals, and we're sort of developing some of the compounds, the cognitive enhancers, to actually try and take this through to the clinic. Our most recent data that we've just collected, which I can't talk about, with the Roche compound looks very, very promising. Really nice recovery profiles. And so we're in the process of sort of negotiating with them at the moment to try and take it to the next step. Do we see similar changes in our sites of activation that we see in our animal systems? Do we see them across all animal systems? Likewise, do we see them in humans? And so at the moment we're looking at that with the idea that potentially in 1 to 2 years, depending on the funding from Roche, whether we can take this into clinic. But certainly the data look very promising, and Roche are extremely excited about that. So this is a watch and see. Certainly if it does go to clinical trial, then the clinical trials will be set up between New Zealand and Australia initially. And I'm in direct contact with the Stroke Foundation and Neurological Foundation, so we'll, as well as the newspapers, so hopefully the audience will, and the general public will be following it just as closely as we are. So, thank you.